A 72-year-old male retired carpenter presents with progressive shortness of breath and persistent, dull right-sided chest pain. I am showing you his posteroanterior chest radiograph and an axial chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates a large right-sided pleural effusion associated with irregular nodular pleural thickening wrapping around the right lung. There is a noticeable volume loss of the right hemithorax, with narrowing of the right intercostal spaces and a mild shift of the mediastinum to the right. The axial computed tomography scan confirms circumferential nodular right pleural thickening measuring up to 2 centimeters, which involves the mediastinal, costal, and diaphragmatic pleura. A few focal calcifications are seen engulfed within the pleural rind. These findings are highly characteristic of malignant pleural thickening, with malignant pleural mesothelioma being the primary diagnosis.
What 4 specific imaging features distinguish malignant pleural thickening from benign pleural disease on computed tomography, and which is more common? Pleural metastases or malignant mesothelioma?
The 4 key features indicative of malignant pleural thickening are thickening greater than 1 centimeter, pleural nodularity, a circumferential growth pattern wrapping around the lung, and involvement of the mediastinal pleura. Pleural metastases from other primary malignancies, such as lung or breast adenocarcinoma, are significantly more common than primary malignant pleural mesothelioma.
What is the typical latency period between asbestos exposure and the development of mesothelioma? How do you explain the presence of pleural calcifications in these patients? And what are the key magnetic resonance imaging findings that would preclude surgical resection?
The latency period is very long, typically between 30 and 40 years. The pleural calcifications seen on computed tomography in approximately 20% of patients represent the engulfment of pre-existing, benign asbestos-related plaques by the growing malignant tumor, rather than tumor calcification. Precludes to surgical resection, such as extrapleural pneumonectomy, include invasion through the diaphragm into the abdomen, direct invasion of the chest wall or vertebral bodies, and invasion of vital mediastinal structures like the heart or great vessels. Magnetic resonance imaging is superior to computed tomography in evaluating these tissue interfaces. I would recommend referring the patient to thoracic oncology and thoracic surgery.